We are the NMAP.
We heal with zeal.
Together, we navigate
New frontiers.
I am Dr. Mahesh Sambhare, consultant in pediatric neurology, based in Navi Mumbai and Raigad. So today's topic for discussion is febrile seizures. So it's simple and straightforward topic. It's not free of controversies, and that starts from its name. So what to write, whether it's febrile seizure or febrile convulsion. So see, convulsion is a clinical epileptic jerking, and most of time in febrile seizure it's lacking. What we see is just a blank stare, uncommunicable kid, or maybe minimal stiffening. So write always febrile seizure and never write febrile convulsion. Second, about age limit, we all know it's from 5 months to 5 years, or maybe 6 months to 60 months. However, ILA, that is International League Against Epilepsy, defines that any kid seizing after 1 month of age with fever, without intracranial infection, or without any provoked cause should be labeled as in febrile seizure. We know these types. It may be simple, or it may be complex, or typical, atypical. So those seizures which are prolonged, lasting more than 15 minutes, those seizures which are focal at its onset, or multiple, more than one seizure within that febrile illness, should be taken as an complex febrile seizure or atypical febrile seizures. We come across confusing states sometime where we don't know whether those were febrile or afebrile seizures. Like see, patient seizes at home, mother confidently tell there was no fever at the time of seizure. Within few minutes, patient presents to the clinician and you document fever. So in those cases, whether that was febrile or febrile. Now see, nearly 20% of the febrile seizure, they occur within first hour of febrile illness. So that's the time when you have rising core temperature, however the extremities are still cold. So this was a febrile seizure. Treat accordingly. Sometimes it happens that the patient seizes during the febrile illness, but during the afebrile state of the febrile illness. This is what is called as afebrile febrile seizure, which is a subtype of febrile seizure and should be treated like a febrile seizure. So no long-term antiepileptic indicated. Something what needs special mention is about the febrile status epilepticus. It's because it's well documented that febrile status may lead to hippocampal sclerosis, which will lead to temporal lobe seizures, which will lead to cognitive decline, which will lead to behavioral deterioration and refractory seizures. So, though febrile seizures are benign, febrile status epilepticus is not a benign condition and should be treated very urgently. Now, febrile seizures has a spectrum, where you have most benign end and fortunately very common end is febrile, which are typical or atypical febrile seizures. Fortunately, the most malignant end are syndromes which we get Dravet or Douze syndrome, and fortunately these are rare to see. They have refractory seizures, pleomorphic seizures, they have bad EEGs, and they decline in all domains. So they have speech regression, they have cognitive regression, they have motor regression. These are the kids usually show mutation in SCN1A gene, which is a sodium channel gene. The types of febrile seizure which these kids get, they have seizure onset below 6 months of age. They have recurrent seizures, they have refractory seizures, they have focal seizures. So any seizures that's occurring, any febrile seizures that's occurring below 6 months of age, you should be alert regarding these syndromes. Now regarding investigation, lumbar puncture is usually indicated in those kids below 1 year of age, and it's always indicated in those kids below 6 months of age, or if it's indicated clinically. EEG is not indicated in typical febrile seizures. It's usually in some of the atypical febrile seizures and all those which have syndromic evolution. Regarding MRI is something which is not routinely indicated in febrile seizures. It's indicated only in cases of febrile status epilepticus or febrile focal status epilepticus, or in those kids who develop torse paralysis following febrile illness. It is just 0.4% of the patient with febrile seizure develops torse paralysis. Now regarding the treatment part, you can use clobazam for the initial 2 to 3 days of the febrile illness. To some extent, it prevents, but it doesn't guarantee for febrile seizures. The dose is just 0.5 to 0.8 milligram per kg OD basis. Now here, even though the fever lasts for more than a week, this clobazam prophylaxis should be used only for initial 2 to 3 days. Second, use midazolam nasal spray if seizure lasts for more than 2 to 3 minutes. Here each midazolam puff delivers usually 0.5 milligram of midazolam. So for 10 kg that comes to be 4 puff. You calculate accordingly. Second strength is that of 1.25 milligram, which is usually used in adults. So always write on midazolam spray this strength in the bracket, whether it's 0.5 or 1.25. Third, there is no role of long-term antiepileptic in febrile seizures. Again, except in those kids which have prolonged refractory febrile status, because even a single febrile status may be damaging, may cause permanent damage, permanent morbidity. So only in these kids long-term antiepileptic is indicated. Phenobarbital is most efficacious, however it has side effect. So can we use levetiracetam or even can use valproate if the age is later after 2 years of age. So this was in short about febrile seizures. Thanks a lot.